We have the great pleasure of hosting Evelyn Sandeen, PhD. She is here. She has connected with us from the USA, from Albuquerque. It's 45 degrees Celsius centigrade, right? There, whatever that is in Fahrenheit. Really, we're very grateful, despite this hot weather, despite this scorching weather, you have been kind enough to join us and to focus on this. She is a clinical psychologist. She's a psychotherapist, and as far as I understand, her doctoral dissertation was actually with Professor William Miller. Is that correct? Or have I? Am I not getting anything wrong? Professor Miller actually recommended Evelyn. She was his student, and I believe that she will give us some excellent support in what we're doing. I hope I didn't get that wrong. Could you confirm this for us, please? And I also wanted to mention that today we are going to deal with a very important topic related to understanding trauma in a very broad approach. And we're going to talk about understanding these very serious problems indeed these people have to struggle with after suffering a trauma. So we want to recognize all these connections, all these interrelationships, these things that drive also these tough symptoms that these people have been experiencing. So today, a very important topic, an in-depth look at what is really going on with these individuals who suffer so much, who have suffered so much. So thank you once again for being here with us, and thank you for giving us your time and for contributing your knowledge and expertise. So now, Evelyn, the floor is yours.
Are you ready for me?
Yes.
Okay. It's a very unusual situation to be introduced and not understand what's been said. I'm so happy to be with you guys today, and thank you so much for having me. What I'm going to share with you comes from my work as a director of training, and I sincerely hope it'll be of use to you in your very worthwhile project. So I'm going to start.
I'm sorry,
here.
I don't want to interrupt, Evelyn, but I'm not sure if you have switched off the translation button. Maybe this is why you didn't understand what I was saying, and I was trying to greet you and say a few things about you and your work. That's quite important. Is this okay? Can you switch? Can you see it? Yeah.
Yes.
And so let me just
I thought
ask.
I did.
Okay. All right. So hopefully you will be yes, everything will be fine. Thank you so much.
Very good.
Thanks.
Okay. Yeah, I'm just very pleased to be here. So let's go ahead and start. Okay, so what I'll be talking with you today about is using network theory to form your clinical conceptualization. And what I hope for this to be is to serve as a bridge between the patient in front of you and the treatment literature. So how to access the treatment literature to do the best job for the person who's in front of you. I come to this with a lot of humility because I think that doing psychotherapy is a very challenging task under the best of circumstances. And these are some of the challenges of psychotherapy. How to create a collaborative alliance with your patient, how to form a clinical conceptualization that actually drives treatment, how to search the literature so that we are doing science-based interventions, but how to search it in a way that actually provides information for your client. And finally, how to know if you're actually helping. And then I come to you guys with a lot of humility also because I don't understand the culture that you're in, the cultures that you're working with, only at a very superficial level. But these are some of the challenges that I imagine that you are facing. Language and cultural barriers between Polish providers and Ukrainian patients, both subtle and obvious, I would imagine. People with multiple serious problems. I don't know your setting. I don't know in what situations you're seeing your patients, your Ukrainian refugee patients. So I'm not sure that you're in a setting that lends itself to a comprehensive assessment. I'm not sure about that. If I were in your shoes, I would be confused when confronted with somebody who has multiple problems. I would be confused about where to start and what is the right timing for various interventions. We do best, I think, in psychotherapy when we have an aspirational goal. And the aspirational goal that I always try to fulfill within psychotherapy is that we're doing things in a systematic way. We can't always do it that way, but that is the goal. And this is what I would call the cycle of competent care. We start with assessment, go on to case conceptualization. From there, go to goals and treatment plan and therapeutic style choices. And from there, we have to have the skills, I'm calling them micro skills here, that allow the therapist to actually do the treatment plan. And then ideally, we evaluate progress toward goals. So for tonight, what I want to focus on mainly is the idiographic conceptualization process, how to clinically conceptualize in a useful way. We'll pay some attention to assessment and treatment planning because you have to have a good assessment in order to do a good conceptualization. I want to promote an iterative process, meaning it's ongoing. Assessment is always ongoing. And then we tweak and change our treatment plan based on that and change our conceptualization. I really want to promote the use of both evidence-based psychotherapies, that is protocol types of psychotherapies, and evidence-based interventions that are not protocol-based, that are based in the larger psychological and biopsychosocial research. And also I want to focus on areas that might be of particular help to you. So we'll start with assessment. I'm making an assumption, which may or may not be true, that you all will be primarily doing interview-based assessment, meaning you'll get your information from the clients themselves through interview with the help of translators, I understand. I'm assuming that you're not going to be doing heavily test-based assessment, such as personality tests and so forth. So within interview-based assessment, I want to identify what, from my point of view, are the necessary domains of human functioning to investigate. And I want to give some pointers, again, from my point of view, of areas to focus on with your displaced, multiply traumatized population, things to be sure to assess. Before we go there, let's talk for a minute about why do we need a broad assessment strategy to prepare for psychotherapy. I think that effective psychotherapy requires it. And even though I'm promoting a broad assessment strategy, I think You can still be very efficient in doing this. And again, it's an iterative process, meaning we won't learn everything until we begin working with a person. Assessment is always ongoing. Without broad assessment, I feel we may be like the story of the 9 blind men and the elephant. I'm not sure if you all are familiar with that story. As I understand it, it comes from India. And the basis is that there are 9 blind men in a village, and they hear that an elephant is outside the village. They've never encountered an elephant before. And so they decide to go out and investigate. And this is what they come up with. They're all looking at different pieces of the elephant. The one who's looking at the tail or encountering the tail with his hands says it's a rope. Another person encounters the sides and says it's a wall. Another encounters the trunk and says it's a snake, and so forth. In the story, the blind men all go back to the village and start arguing about who's right. Now, in reality, they're all right, but they're not completely right. They're all wrong as well, because they've focused on only one narrow piece of the elephant. They're not seeing the whole. So that's my summary of why we need broad assessment. We want to be effective. We want to be sensitive to the person and what they are going to accept or reject. We want to use patient strengths whenever possible. Whenever somebody is coming in with a strength, we want to be able to use it in their healing. And we want to pay attention to important issues for a highly traumatized population. And some of these issues are social, cultural, and have to do with meaning building or spirituality or existential stance. So in the US, and I would imagine it's the same in Poland, our medical colleagues always do a review of systems on their first visit with a new patient. And that means that even if you go to a physician with a sore elbow, if this is your first visit, that physician should do a complete review of systems. And the systems they review are, the neurological system, the musculoskeletal system, the digestive system, and so forth. And the reason that they do that is because all symptoms need to be placed within the context of how the individual is doing overall. And I think it's very much the same with psychotherapy. We do, even though we're working on alleviating certain symptoms, we do need to know the whole person in order to do a good job. So I'm going to go through some domains that, in my opinion, are very important for assessment. And I'm just going to first label them, and then we'll talk a little more about them. So everybody should be reviewed for risk assessment. Are they a danger to themselves or others? Their current problem set, what issues are they experiencing right now? We should be looking at their significant lifetime stressors, including ACEs, adverse childhood experiences, and adult stressors. And we should be looking at the person's limits and strengths. Following that, or in conjunction with that, I think we need to assess doing a review of systems. But unlike the medical systems that I just identified, these have to do with a person's psychological functioning. We need to understand their biological functioning, their emotional functioning, their cognitive functioning, relationships, how they function within relationships, what habits and patterns they are engaged in, how they function culturally and socially. And then finally, where are they in relationship to meaning, to values or spirituality? So this is just a caveat that I think is important for most of us to remember, which is that I think we need to collect behavioral data about timelines, events, emotions, reactions, behavior, what's actually happening for this person at a behavioral level. And put off making conclusions until you see the full picture. The conclusion is sort of the conceptualization. So when we're gathering data, we want to keep focused on just getting good behavioral data. And this is an example of what I mean by behavioral data versus conclusions. So for example, on the left, we want to collect data such as how many drinks did they drink per week, rather than on the right, labeling them alcoholic. The second example of behavioral data, we know that our client feels very sad after she has phone calls with a critical mother, rather than labeling or concluding that she has low self-esteem. And the third bullet might be particularly relevant for you all, that a person has low energy and low mood after being displaced, being in a refugee status, and concluding they have PTSD. They may, but they also may not have PTSD. So this is just to give you emphasis on collecting the data before making any conclusions or conceptualizations. This is just an illustration from dialectical behavior therapy, in which we are encouraged to look at the sequence over time of behavioral events. And this is the kind of assessment that we want to be doing when we're doing assessment for conceptualization. We want to know what comes before what, if possible, and what affects what. So from my perspective, given the population you all are working with your Ukrainian population, these are areas that I would really focus on if I were in your shoes. I would really be looking for nervous system agitation and dysregulation. I would really have my eyes peeled. I would really be looking out for any increases in substance use, decreases in self-care, or avoidance patterns of any kind. I would be looking for social isolation, whether this person is isolating. And I would be looking as to whether this person is experiencing a loss of meaning due to the traumas and difficulties they have endured. So going back now to explicating some of the assessment areas, the current problem set is something obviously we want to understand. And so we want to know what are the current distressing behaviors and symptoms as experienced by the person. We also, though, want to know about symptoms or behaviors that perhaps the client doesn't find distressing, but that we as clinicians might be concerned about. And these would include some of the things I referenced a couple of slides ago. If the person is over drinking, for example, or isolating. And then we also want to see, and this will be a big focus when we do the map in the second hour of our presentation today. We want to understand how the problem symptoms or behavior are linked to one another. Does one thing trigger another? Do they occur together? Did they exist prior to the Russian invasion? Or are they completely sequential to the events of wartime? The second topic area is risk assessment. And I'm assuming you guys all have done risk assessment many times. I won't go into all of this, but just in the interest of being complete, I did include it. We want to, of course, assess whether they are at risk from self-harm, or do they have any risk to other people through violence. Moving on to limits and strengths. We really need to know our clients' limits and strengths before we choose an intervention. I think this is obvious, but sometimes we ignore it. So what are their limits? If you guys are specializing in cognitive behavioral therapies, can this person actually perform CBT type homework assignments? Are they capable intellectually, for example, of doing that? Do they have other biologically based limits? It could be psychosis. They might have a psychotic disorder, serious mental illness. They might have other biologically based limits. I think this one is really important for your situation. Do they have agency? Do they believe that they have control at all, even in a small way, over their circumstances and psychological well-being? Are they ambivalent about participating in psychotherapy or changing? Most people are to some extent, but you want to know that before you get into a treatment. You want to know if you have to address ambivalence prior to starting a treatment. And then we also want to know, what are their strengths? Personal traits such as courage, perseverance. Do they have material resources? Do they have social connections that they can exploit for support and help? And do they have helpful ethical or spiritual belief systems that can be exploited in this situation? We want to do a history of what significant stressors have they experienced in their lifetime. So significant stressors are not all criterion A from the DSM PTSD diagnosis, but they are significant to the client. And my suggestion would be, when you are assessing for this, to be careful of the wording, not to place judgment on what has happened to them or make conclusions, but just be asking in very plain language whether they have experienced these things. Some very significant stressors may not be readily apparent to the client. For example, childhood neglect is often not really readily apparent to the client. And the reason that we know stressors, both childhood and current, are so vitally important in understanding in order to conceptualize a case for psychotherapy. In part, we know that because of the very extensive literature on ACEs, or adverse childhood experiences. The research on ACEs is very extensive, very impressive, and basically shows a very high correspondence between the numbers of stressful childhood events and all kinds of psychological and physical difficulties. And this has been shown cross-culturally as well. So we know that significant stressor history is very important. I'm going to briefly go over the adverse childhood experiences, the ACEs. Many of you may be familiar with these. I just want to briefly go over them. that for childhood experiences that have been shown to be have large effects on adult functioning. These are the 3 types of events that have been shown. And I'm going to go again briefly. I'm not going to read them all. I'm sure you guys can get a hold of an ACE questionnaire. If you could get one in Ukrainian, of course, that would be very useful for you. But these are the ACE questions. They are not all equal to psychological traumas, as in PTSD, but they have all been shown to have a cumulative effect on people's adult functioning. So these are questions that you can see are very specific and point to those 3 categories of abuse, neglect, and household dysfunction. Now, these are the areas that I would encourage you to ask about when you're doing your assessment for adult stressors. And once again, these are stressors. These are not necessarily psychological traumas as defined by DSM. And you can see how many of these your patients are likely to have who are refugees from Ukraine. Exposure to combat or first responder events, injury or assaults, including sexual assault, exposure to the assault, injury, or death of others, moral injury situations. And again, you may be familiar with these, but in case you're not familiar with that designation, moral injury has to do with when one's beliefs about what is right and wrong, what is moral, have been violated. Usually moral injury is talked about in the personal sense, that is that you have seen, witnessed personally an event that was wrong, or that you participated in an event that you later thought was wrong. But there's also a way of looking at moral injury that would include larger group events, such that the entire invasion that's going on can be seen as a moral injury situation. Norms of what is right and wrong have been violated. Losses through death. Again, some of your patients are going to have those associated with the invasion, others will not. Having shunning or rejection from family or other meaningful groups is a very powerful adult stressor. Divorce and child custody problems, job losses or failures, chronic microaggressions, meaning being singled out for your cultural status, your race, ethnicity, gender, and being in a hostile environment because of that. Also, any overt racism or targeting for who they are. And then incarceration and legal involvement is a very significant adult stressor. So we want to be evaluating, assessing for all of these. Now we're moving on to the review of systems. And I'm just going to go through these with an eye toward what you guys might really want to be tuned into. So within the biological domain, we want to be looking at their physical health, illness, chronic and acute over their lifetime. And then especially their current bodily state. Given what many of the refugees have been through, it would make a lot of sense that they would be experiencing a great deal of physical tension and nervous system agitation. And this could all be seen through these kinds of symptoms: physical tension, racing heart, trouble eating, trembling, insomnia. We also want to be looking as to whether they have chronic pain, which is a very difficult stressor, and what medications they're taking, including psychoactive substances. Within the emotional domain, I think this will be very important for you guys in sort of assessing what is the right time to initiate a trauma-focused intervention if you decide that that is the thing to do. You're going to have to see where the person is emotionally. Are they able to self-regulate and self-soothe? If they are not, if their emotions have been overrun because of the difficult situations they've been through, they are probably not ready to do a trauma-focused intervention. And you want to probably work on this first. You want to understand if they have emotional awareness. Do they even understand what emotions are and what they're experiencing? Do they have ability to empathize with others? Are they more self-centered? Are they having emotion-driven acting out? Are they having explosive behaviors due to emotion dysregulation? Or on the other hand, are they constricted? Are they having difficulty experiencing emotion? Emotional numbing would be another way to put that. And many people who have trauma reactions do have an emotional constriction or numbing subsequent to the traumatic situation. And then finally, do they understand what emotions are and what they're for, or are they just ignorant of that? Within the relational domain, do they have the ability to form and sustain relationships? You could look at a brief history of relationships to see whether they have been able to have intimate connections with romantic partners or friends or family. How embedded are they or were they in their communities? And do they have grief over specific losses that they've had? It could be acute, having to do with the conflict. It could be historical, that they're still grieving. Within the habits domain, we want to assess how are they doing with substances? Are they using more than they were? Are they beginning to use substances where perhaps they hadn't? Also be looking at other compulsive behaviors, such as sexual acting out, pornography, gaming, gambling, shopping. Many things can be used as an avoidance strategy. And we want to be particularly tuned in to avoidance strategies with this population, because we know that avoidance prolongs a PTSD type reaction. We want to know about their sleeping and eating habits. And we also want to know about positive patterns that they engage in or used to engage in, perhaps prior to their displacement. We want to know, do they exercise? Do they have political affiliations? Do they engage in service? Within the cognitive domain, I think we're looking at what is the quality and type of their thoughts? Do they tend to be ruminative? Are they thinking the same thing over and over, which is the quality of many people's thoughts post-trauma? Do they have OCD tendencies, obsessive compulsive tendencies? Are they self-critical? Are they critical of others? Do they have the depressogenic triad? the depression-causing triad of having global, negative, and stable thoughts about the self. They having fear-based thoughts that produce anxiety, what if thoughts, and how rigid or flexible is their thinking. Flexibility of thought is beginning to gain traction as a sign of good mental health in general. So we're always wanting to know how flexible or rigid are they. And of course, we want to know if they are psychotic, either in content, which would be a delusional system, or in process, which would be a thought disorder. Within the cultural domain, my understanding, which is very limited, is that Ukraine and Poland do share many cultural aspects, but I am also quite certain there are distinct differences. And we want to know from the person's point of view how they see themselves culturally. How do they identify? What is important to them about their identity? And are they doing anything or having any feelings that are normative, that are normal within that culture, that might seem not normal within your culture or suspect in some way? We want to know if they've had any direct experiences of targeting due to their identities. They certainly have experienced that with the invasion. And then especially we want to know any beneficial cultural, religious activities or rituals that they might be able to partake in that would be helpful for them. Within the meaning, values, spirituality domain, we want to know what is your client's view on the meaning of life? Do they believe their life has meaning? What do they value? And do they have a resource in their religion or spirituality or philosophy? Is that something that they can use in recovery right now? And is your client experiencing that moral injury that we just talked about from something they've done or witnessed? So that is my view of what a broad assessment would be like, investigating all of those domains of functioning so that you can now put together a case conceptualization. So we're going to go ahead and start talking about case conceptualization. I would say that case conceptualization is actually the key to effective psychotherapy. I'm not the only one who says this, of course, but I do really believe that without a good case conceptualization, we make many more errors and are not connecting with what is important to the client. So I would say you want to avoid the following if you can. One is having an unarticulated conceptualization. We always have a conceptualization, but as therapists, you want yours to be very clearly articulated if possible. You want to be able to say what you think is going on psychologically, socially with this person in order to target your treatment. We don't want to accept the client's conceptualization entirely. The client's view is extremely important, but it's not a conceptualization. And we also want to avoid conceptualizing only within an intervention. What I mean by that is, for example, I know already that I'm going to do CBT, so I only need to know very few things. I already know that I'm going to do this particular intervention. So I'm just going to conceptualize within the intervention. So let's take a step back and just ask why conceptualization for psychotherapy is important. It should direct everything that happens in psychotherapy. And very important from my point of view, as we are trying to be grounded in the research about human functioning, is that conceptualization is the bridge between the individual in front of you with all of her strengths, weaknesses, specific past history, and the treatment literature, because the treatment literature has not been written about your particular patient. It's been written about aspects of what she may present to you. So I'm looking at conceptualization as the way that we can access the literature in productive ways to formulate a evidence-based, research-grounded intervention strategy. Conceptualization should also help us to determine the prioritization of treatment. What needs to happen first, second, third? It doesn't give us the final answer. We always have to try it first and see if it works, but it gives us hypotheses in what direction to go and what to try first and second. Another argument is we already have conceptualization because we have psychiatric diagnoses. And we don't need conceptualization because we also have treatment protocols and evidence-based psychotherapies that follow from those diagnoses. So why not just diagnose somebody? And that serves as your conceptualization. So here are some problems with using psychiatric diagnosis as your conceptualization. Patients may not fit a diagnosis. They might fit several diagnoses. And I'm sure you have encountered this. There is huge symptom overlap between different psychiatric diagnoses. When I was working at the VA, working with veterans who had been traumatized, we often forgot to specifically diagnose them with depression in addition to PTSD because there was so much overlap. It was basically impossible to find somebody who had severe PTSD who did not also meet criteria for depression of some type. There's huge, huge overlap. There's huge overlap between depression and anxiety. And interestingly, there's huge variability of presentation within a given psychiatric diagnosis. Somebody has done the arithmetic and there are 636,120 different permutations of symptoms that meet criteria for a PTSD diagnosis under DSM-5. So we have huge heterogeneity within a diagnosis. So these are some of the reasons why psychiatric diagnosis is less than perfect as a conceptualization. What about evidence-based protocols for different diagnostic groups? I value evidence-based protocols greatly. They can be very effective. However, many of the problem sets of our clients do not fit neatly into a protocol. And as we said before, many of our clients carry more than one psychiatric diagnosis. So yes, absolutely use protocols when they're appropriate. But for many patients, they're not appropriate or they're not the only thing that's appropriate. So I think this would be a good break. We're a little bit short of an hour, but this would be a good time to take a break for 5 to 10 minutes, and then we will start on the conceptualization section. So having just given you some problems with using psychiatric diagnosis as a conceptualization, I want to give you an alternative framework that my students and I have found very helpful. And it's based in network theory, which you may or may not have heard of. But network analysis is a very statistic-heavy branch of research in which they are fitting statistical models to clinical data. And what they are doing is in a group data setting, taking the data from many people, they are able to statistically estimate the strength of relationships between various symptoms. They're especially interested in what they call the identification of central nodes. So the theory is that symptoms influence one another, and that these symptoms can go into a steady state where they each maintain other dysfunctional symptoms. So instead of looking through a lens of psychiatric diagnosis, that the diagnosis is causing these symptoms, we're just putting that aside completely and just looking at the symptoms that the patient is presenting and how they interact with each other. So, for example, nighttime insomnia, irritability, anxiety, low activity level, relationship conflict, and low mood are all symptoms that can coexist in one person. Network theory is mapping this statistically to determine the strength of the relationships. So the next slide is it's just a made up map, just an example to give you an idea of, in network theory, what they might find. And to pay attention that the central node, the thing that influences the most other symptoms, in this case is insomnia. So this is a very simple sort of map of the network, the relationships between various symptoms. And what we have here going from the left, we have low activity level, low mood, anxiety, relationship conflict, irritability, and insomnia. And what we can see here is that relationship conflict has relatively low relationship, but some relationship to anxiety and irritability, but that insomnia has strong relationships to anxiety, low mood, low activity level, and irritability. So in this example, insomnia would be seen as a central node. So what we're doing with the idiographic network mapping for clinical work is we are using the concept put forward by network theory. We're not doing sophisticated statistics. We're not doing any statistics, but we are using the concept that instead of looking at diagnoses, let's look at how symptoms present and how they are related to one another and how they can maintain one another. So the map that we have come up with is just a framework for your conceptualization. It maps the patient's problem set and how the symptoms interact with each other. We don't know this at the beginning of working with somebody, but we can have hypotheses. So the map at first is looking at hypotheses of what influences what. And you're getting at some of that with your questions, those nice behavioral questions of, you know, when and what comes first. It's idiographic. It's about the patient. It's not about diagnoses. It's most useful for patients who have a lot of issues going on and who do not cleanly fit into one diagnosis. It includes all the significant findings from your review of systems, from your assessment, and it includes client strengths. an important advantage, I think, is that it includes everything in shorthand on one page. So this is an example. This is not an example. This is just the map. So at the top are just those domains that we assessed during the review of systems. Starting with the top left, we're going to put in there the presenting problem. What is it that the client is saying? And then the yellow pentagons are significant life events that you have gleaned from your assessment. At the bottom are strengths of the client. And at the top right are limits, anything that you need to take into account as you are treatment planning. So remember, a limit could be, for example, ambivalence about even doing psychotherapy, and you might have to address that first. Or another limit could be not able to do homework that would be required for a CBT intervention. Then the most important piece of the map is what's going on inside of the oval. Inside of the oval is the person and his or her symptoms. So we're just putting those in, and then we are hypothesizing relationships. And we'll go into some examples from some hypothesized cases in just a moment. So just a word about what a map is. It's a map sort of the person and what's going on with them. They include all relevant features. Everything important is there, but they do not tell you where to go. This is not a theoretical structure. It is more a data clarification and a data management framework for you to make your own decisions, to go to the literature and decide what kinds of interventions might be good for this person. So we are going to use the map to identify and prioritize treatment targets. We are looking for those central nodes. Remember a few slides ago in network theory, they're very interested in central nodes. What symptom or behavior is maintaining other symptoms and behaviors? So we need to ask those questions about timing and causation. So when is the anxiety worse? What makes it better? Are you ever free of anxiety, for example? Just a word about how to treatment plan based on the map. And again, we're going to go into examples. I think it'll become more clear. But we want to review limits and strengths for the patient. We want to be sure to include strengths. We want to be sure to take into account any limits they have. We want to provide all the most important information, and we want to make sure that the targets tie directly to the client's goals. So as we prioritize, we're going to look for central nodes on your map. And these are a change that could make a difference, the difference that could make a difference. We're looking at what symptoms or behaviors cause more problems. And we're looking at the question, what needs to happen before other things can happen? So for example, if a person has very low agency or belief that they can do anything to help themselves, we might have to work on that before embarking on any kind of protocol. If they don't believe that they can make any change in their life that is important and will help them, they're almost certainly not going to do homework, for example, for a CBT protocol. So I hope you're picking up that I'm very, very firmly in favor of evidence-based treatment planning. However, I think evidence-based treatment planning and evidence-based psychotherapies are two different things. So once we know the targets on our map, then we're going to look as to what might be an appropriate intervention. Sometimes it's going to be an EVP. Other times it's not going to be an EBP, but hopefully it will be rooted in the broad psychological literature. For example, the finding that social support is essential for healthy human functioning is not an EBP, but it is a very, very well documented bit of evidence in the psychological literature. Low social support and loneliness can be as deadly as cigarette smoking for longevity, for example. So we're looking very broadly in the literature for what might be applicable for this person in front of us. These are just some things that when I was trying to put myself in your situation of working with the Ukrainian refugees, these are some things that I think might be interventions for you really to be looking at very closely, that they might have wide applicability for many people in the situation of your patients. We want to really make a priority of soothing the nervous system. Probably the great majority of people you're going to be working with or are working with have an agitated nervous system due to what they've been through. So interventions such as relaxation training, mindfulness, meditation, exercise, aerobic exercise, but also yoga and touch, calming touch. So it could be massage, hugging appropriate people, self-care activities, and then assessing appropriate social support. Family, of course, if they're able to be supportive, if they themselves are not so traumatized or so unavailable that they can't be of help. Age peers, if you all have any ability to help formulate groups, support groups for your Ukrainian refugee patients, I would really encourage you to think about forming groups of perhaps teenagers or elders who can support one another and have certain characteristics in common. There could also be groups formed according to what experiences they have undergone. So, for example, grief groups can be very helpful. Political groups can give meaning and direction for people who are struggling in that way, and religious groups for those who already have a religious background and for whom it's been positive. And then universally, I'm sure you've heard this from other speakers as well, improving your patient's sense of control and agency is very, very important. Helping structure anything you can to help them make day-to-day decisions for themselves, and especially behavior activation. The behavior activation literature is primarily for depression, but it's very helpful in structuring and giving control to somebody who feels low control. And then finally, addressing meaning. Most people who go through such cataclysmic events as becoming refugees have issues of meaning. Values clarification and ACT, acceptance and commitment therapies, may be helpful here. Being of service is one of the main ways to address meaning. Opportunities for valued action, being on the lookout for whatever that person values, can they act on their values? And religious or spiritual support, again, if they already have that as a background, if it's already been helpful for them. Okay. And then finally, I really want you guys to be on the lookout for short-term solutions from the client's perspective that can become the problem. And we know this from PTSD work, that many of the issues that maintain PTSD have to do with avoidance strategies. And while it makes all the sense in the world that somebody would want to avoid feeling terrible and anxious and distraught, these avoidance strategies typically turn out, if they're held over the long term, to cause further problems and to continue to maintain PTSD. So you want to be on the lookout for avoidance of all kinds, social isolation, low activity level, and substance use or any other compulsive behavior. All of those things can seem like really good ideas at the time, but can go on to become their own problems. So I want to go through a few cases completely made up on my part, but just trying to brainstorm the different kinds of problem sets that you're likely to encounter. And again, I could be wildly wrong on this. This is just coming from my experience with traumatized people and how differently they can present, how differently they can, the trauma can live through them or the difficult situation. So the first case I'm calling Katerina. She is a 35-year-old refugee. She traveled with her parents and small children soon after the invasion. Her husband stayed behind. At the time that you're seeing her, she has lost her sense of security, obviously, been uprooted from everything she knows. But her home is still currently intact. Her husband may be at risk, but he is in regular contact with her. She has not had any deaths of persons close to her, and she has not visualized any death or injury firsthand. She has a full range of emotion. So this is an example of how you might map somebody who's coming to you with the problem set and the background of Katerina. On the upper left, this is what she is saying. I'm very worried about my family's future, which understandable. In the yellow pentagons are important events from her past. So she had worked in a university setting. She fled soon after the invasion. She has a low ACE score. And on the bottom are her strengths. She's intelligent and educated. She was financially secure prior to the invasion. She relates well in session. She has strong values. She's very patriotic. She has strong values of helping others. So within the blue oval is what, through your assessment, you have picked up about Katerina. These are the primary symptoms and behaviors that she's displaying right now. So you can see on the lower right, she is bored. She lacks a daily structure. And we are hypothesizing with the directionality here. It's just a hypothesis, but we are hypothesizing that this boredom and lack of structure gives lots of room for ruminative, fearful thinking. So from ruminative, fearful thinking, meaning thinking over and over, what if this, what if that, what if this? From that comes, she has sadness and crying spells that typically follow a period of ruminative thinking. The fearful thinking also causes her to drink more than usual. And when she drinks more than usual, she has more crying spells. When she drinks more than usual, she also finds herself very tired and has poor interactions with her children. So what we're looking at with that map, we're looking for centrality. And if we go back for a second, what looks to be the most central symptom here? To me, it looks like that ruminative thinking is very central. It also looks, though, that you can see that the drinking could be very problematic and that it could be a lack of daily structure that's leading to the rumination. So that's sort of the takeaways from looking at that map for me. We want to look at what's central, what needs to happen first. So here is a possible treatment plan for Katerina. One aspect of it could be cognitive therapy for anxiety, disputing her fearful thoughts, her what if thoughts, helping her to work actively with her thinking and dispute those thoughts that give her lots of anxiety. Another aspect of the treatment plan could be mindfulness practice, learning to identify when she's ruminating through mindful periods of self-observation. That can be very helpful for rumination. And how can we utilize her strengths? She's an intelligent person. She is understanding what psychotherapy is, so she's a good candidate for cognitive work. She's also service-oriented, she's personable, she's educated. So my question, if I were working with her, is, can you be of service? What can you do to be of service and structure your day? So that's an example. That is definitely not the only treatment plan possible from that map, but it is a treatment plan. If you went ahead and did these things, then you would be looking at how effective are they? Are they helping her? Here's a second case that I'm calling Ivan. Ivan is a 72-year-old man who traveled with his daughter-in-law and grandchildren to Poland after a month of heavy bombardment. He endured food shortages and many nights in bomb shelters. He did not lose anyone close to him, but he did see destruction and dead bodies during evacuation. He had many adverse childhood experiences during his own childhood. He was abused by his father in particular, and he's very identified with his Orthodox religion. So here's a map for Ivan. His presenting complaint, what he says is, I feel useless and tired. In the yellow pentagons are some of the important information. He has high ACEs. He had an abusive childhood. He was taught that men should always protect their families. He was had to be exposed to prolonged danger, and he was prevented from taking action during the bombing. In terms of his strengths, he was a retired plumber. He was an active person, active in his community. He has a strong religious faith, and he is close with his family. So then if we look within the oval at his current symptom picture, we see a lot of arrows here because everything's related to everything. But we're seeing that he has low agency and a high feeling of powerlessness. He has a feeling of hopelessness. And you can understand how that is connected both to his childhood experience of being abused and to his recent traumatic experience of being in under bombardment and not being able to do anything other than hide. He has low energy and concentration. He's having just general dysphoria, general sadness and unhappiness. He has nervous system agitation and body tension, self-critical thoughts, and poor sleep. So if we look at our hypothesized directionality here, what looks like a central node to you? To me, it looks like you could go several ways, but definitely his nervous system agitation and body tension. Importantly, in the red pentagon, he does not believe that therapy will work. He's not a man of an age where therapy was common, and he doesn't really believe in it. He doesn't understand it, doesn't know what it is really. So you could see that self-critical thoughts might be a great target for a cognitive behavior therapy intervention, but maybe not for Ivan, because he may not really understand or be a particularly good candidate because he doesn't believe in therapy being effective at this point. So in terms of prioritization, I would say maybe the nervous system agitation. What can we do to help him with that? And also, how can we utilize his strengths? So from my point of view, the nervous system agitation seemed to be central and lead to other symptoms: his poor sleep, his self-criticism for being weak, and low energy. And his feeling of low agency, as I mentioned, comes from his abusive childhood, an inability to protect his family, and just feeling low energy and tired. So a possible treatment plan for Ivan could be helping him to engage in some physical self-soothing. I've often worked with clients to have them put their hands on their chest as a self-soothing, or even hug themselves as a self-soothing. It usually calms the nervous system to some extent. Progressive muscle relaxation, which I'm sure you're familiar with, might be something that he would be willing to be taught. Relaxing breath, and he might be willing to be guided toward doing more exercise depending on his physical status. Ivan seems to me to be somebody who might benefit from supportive or educational therapy, perhaps in a group, perhaps with elders, so that he could learn something about trauma and learn to normalize his reaction. And then he has a strong affiliation with his Orthodox faith. Can he be encouraged to continue to participate in that? Will that help him? And service to others might be a good way for him to gain more sense of control and agency. Here's another hypothetical case. Olga, 21-year-old woman who is a university student. She was personally injured by shrapnel when out shopping. She was treated for her injuries successfully in Ukraine over 3 months ago. She evacuated to Poland with sisters 13 and 17, and her parents stayed in Ukraine. So this is a map of our hypothetical patient. Her main thing is, I don't want to talk about it. Her parents appear to be safe at this point. She had a good childhood, but she did experience a very severe trauma to her person. In terms of her strengths, she had close ties with her sisters and parents prior to the invasion. She does have strong patriotic values, and she is intelligent and educated. Now, if we look at her network map within the blue oval, you can see she has avoidance. She avoids talking to her sisters and parents because they always want to know how she's doing, and she doesn't want to talk about it. She's isolating socially. She has constant thoughts of danger and doom. She has poor sleep. She has emotional numbing. And these are all connected with her intrusive symptoms. She has lots of images and dreams of the traumatic events she experienced. So this is one that looks like a pretty straightforward PTSD diagnosis. And this is a case in which, if she is willing to participate in psychotherapy, and she might be because she's a younger, educated person, that an EBP, an evidence-based psychotherapy for trauma, might be very appropriate. So the ones we have the most evidence for are prolonged exposure, cognitive processing therapy, and EMDR, eye movement desensitization and reprocessing. I've used all three of those. I'm sure many of you have also. And they're all effective for different people. I don't think we have a lot of evidence about matching patient to treatment for the trauma focused treatments. But she might not be open to the evidence-based psychotherapy. All of them do require some discussion of the traumatic event prior to engaging in the therapy, some more than others. EMDR takes the least amount of, requires the least amount of discussion of the event, but all of them confront the event directly. So she may not be open to it. In that case, I think just having a supportive relationship where she begins to tell the outlines of the story, or she begins to talk about how she's feeling now, might be an entry to evidence-based psychotherapy. She could also be educated about the nature of trauma and what she's experiencing. We would really want to utilize her strengths to connect to other refugees through service. We want to try to get her to reconnect with parents and siblings. Those are such important bonds. And encourage her to share her story with peers and relatives if she doesn't want to share it within psychotherapy. And the last hypothetical case I have for you is Nadia, a 15-year-old girl. She unfortunately had her father killed in combat. She evacuated to Poland with her mother and two younger siblings, and her extended family is still in Ukraine, apparently safe. She is missing her father and very distraught about this. I miss him so much. Why did he have to die? She had a happy childhood. She is a young person, had no significant losses prior to the invasion. Her father was killed, and she has typically 15-year-old immature values in the face of loss. And what I mean by that is she's taking it in a very self-centered way, which is very understandable for a 15-year-old. Her strengths: she is artistic. She's a painter, a poet, a violinist. She had many good friends in school, and she has a supportive extended family. What we're seeing in terms of the network of her symptoms is that she's having a lot of intrusive thoughts about her father's death. These lead to self-critical thoughts about her, that she should have been a better daughter, she should have done something different. She's having frequent crying spells, dysphoria. She's isolating socially, has low activity and low energy. So if you look for central nodes here, where would you look in terms of something that you could target? There's a few candidates here. I would go personally with social isolation and low activity level, because these are contributing to her dysphoria. We want to decrease her self-critical thoughts. She was a perfectly fine daughter. She was a teenager and her father was killed. We want to facilitate grieving and remembering her father's life as well as his death. So here's a possible treatment plan for Nadia. Behavior activation, having her schedule social and other activities to increase her activity level. This should decrease her depression and dysphoria. Cognitive therapy to dispute her thoughts about being a bad daughter. And grief facilitation, possibly using her artistic strengths here. She could write about memories of her father. She could create artwork. And I think values clarification or acceptance and commitment therapy ACT. We could help Nadia identify what her values are and see if she can take value-driven action. Sometimes people who have lost a family member can take on or imagine their values, the dead person's values, and sometimes it's meaningful for them to act in line with those values. So I may have done something wrong and not be able to hear the translators, but do we have questions that I could answer at this point? Okay, not hearing any. I believe that we're able to share in the chat a couple of resources if you're interested in trying this with your patients, a couple of worksheets that are in English, but that might help you in doing that. So potentially we could share those before we're done today. And then I want to speak briefly about where do we go from here? Now that we have a case conceptualization in the form of a network map, now how do we, and I gave you certainly some ideas about how to treatment plan from that. But we have some decisions to make. We have to make goals with the patient. We have to get them on board with whatever the treatment plan is. So collaborative goal setting is the piece of the therapy that is from the patient's or the client's point of view. The target is what we identified before. It could come from an analysis of the centrality of a particular symptom that we really want to work on, say, low activity level, because our theoretically based belief is that if we work on low activity level, that will lead to other positive changes. When we're working with clients, we need to make sure that the goals are specific, clear, and important to your clients. And as clinicians, our job is to tie the client's goals to what we're seeing clinically. We want them to be one and the same if possible, through a good therapy relationship and through being tied to theory in a positive way and evidence-based treatments. I think we can convince our patients most of the time to do the thing that we believe will be helpful for them. But sometimes we can't. And we, of course, then have to go with whatever the client is having as a goal. You've probably heard about SMART goals. That's, of course, an English acronym that stands for specific, measurable, achievable, realistic, and timely. So we want to translate any goals of the patient into very concrete goals so that we know when they have achieved them and they know when they've achieved them. So, for example, get over my PTSD might be a goal from the patient's point of view, but we would have to translate that into something more specific and achievable. It might be able to overcome my avoidance and attend my children's school functions on a regular basis, for example. Then, of course, once we've decided on the goals, once we've done our case conceptualization, we know where we want to go. The therapist has to have the skills to implement the treatment plan. And here, there's many, many more skills that we need as therapists, but we do need to provide accurate empathy to really understand what the person is explaining to us, what their sense of the situation is. We need to ask clear assessment questions. We have to present the conceptualization and negotiate goals in a clear manner. If you choose to try out the map, I have certainly shared the map with clients many times, and they find it understandable. They seem to like it. It helps explain why you would be targeting a particular symptom or what the treatment is designed to do. So I find it to be a very helpful technique in terms of getting your client on board with effective treatment that you're hypothesizing will be effective. The therapist needs to agenda set for every therapy session, I believe. I'm sure you guys are doing that as part of your CBT training. Need to manage time within the session. If we can't manage time, we're not going to deliver our beautiful interventions. I always give homework, and you need to assign it in a way that's very clear and review it. And if we're talking about evidence-based psychotherapies, of course, as being part of this process, we need to have training as much as possible in the various evidence-based psychotherapies. And then finally, ideally, we want to evaluate progress toward goals. We can't always do this, but we want to be noticing what direction the person is going in and doing the best we can to evaluate progress. So it could just be as simple as achieving those initial goals of therapy. So increased behavioral activation, you'd want it to be more specific. You'd want it to be having 4 regular outings a week, something like that. Doing grocery shopping plus something fun plus activities for the kids, as an example. Stop drinking, if that was the negotiated goal. Socialize more often, or complete CBT, cognitive behavior therapy, homework regularly. So just achieving those goals could be your outcome. And of course, I'm sure you guys are familiar with these. This is a whole bunch of validated measures, self-report measures. I don't know the status of how many of these are available to you, but they're very quick. And if it would be available to you to give to your Ukrainian patients, I would highly recommend that you do so. It gives you a good understanding of where they are. The first ones are for depression, anxiety, substance use, and PTSD. But then there are also measures of therapeutic relationship quality that are very helpful to get an idea of, does this person feel understood and on board with what we're doing? And then finally, if therapy is not helping, we need to go back to the drawing board. This happens many times in psychotherapy. There are things that we don't know until we know them. We go down a route that seems very reasonable and theoretically or evidence-driven, and it turns out to not be helpful for this person. Or we underestimated ambivalence or low agency, and they just don't do the work. They're not interested, or they're overwhelmed. So many, many reasons for the initial conceptualization and treatment plan to not work. And we just have to go back and have humility about it and not just keep doing the same thing, only more of it. We have to really rethink things, I believe, and see if we can see it from another perspective. We should look at what new information do we have. We can do more assessment. We can look at, are we in a good therapeutic alliance together? Or is there something missing? And I would imagine this will be an extra challenge if you're going cross-culturally, across languages. This is going to be a real challenge to make sure that the therapeutic alliance is one that is promoting the therapy of the patient. And of course, you just have to keep going, seek consultation. Hopefully you guys have consultation groups that you can tap into. But iterative adjustment is absolutely normal and necessary. So I did include in this some resources for you, just in terms of some articles. We should always be going to the literature to find things that might pertain to our clients. But these are a few things that I mentioned today that I just wanted to give you as resources. So to summarize, I think my major points to you all is to try out doing this broad assessment that I was promoting, or something similar. There's nothing magic about what I put forward, but trying to see the whole person and not be like the blind man and the elephant and only concentrate on one piece of the person. Try to do a broad assessment. Put that assessment together in some form so that you're really looking at how symptoms interact with one another. I think that may give you a little more traction than doing psychiatric diagnosis only. And then from that conceptualization, going to the broad psychological literature to see what you can do within the constraints that you have to put together a good treatment plan. And finally, to evaluate if your treatment plan is working. So that's what I have for you today. I sincerely hope that some or part of it has been useful to you and you can try it out with your clients. Again, I think I did something wrong with my screen and I am not getting interpretation, but if there's a way to get me any questions, I'd be happy to answer questions at this point.
Tak, mamy pytanie, tylko czy...
Yes, we have a question, but can you hear us? Can you hear the translation? Hello? Can you hear the translation? Well, apparently not. Okay.
Evelyn, hi. There are questions, but I wonder whether you can hear the translation, because
No.
yes. What about the button, the famous button? Can you press it again? Because it looks that the translation.
I tried
really
twice, but I will
working.
try again. Yeah.
Mm-hmm. What about now?
Okay, can you hear us now? Hello? Hello, hello, testing the interpretation. Can you hear the translation? Can you hear the translation or not?
It doesn't look she can, no. What does Evelyn?
I don't think I can do that. I'm sorry.
Yes.
Na czacie po angielsku zadała ta pani, która
Yes,
pytała.
there's a question in the chat, so maybe let's read it just straight from the chat, because it's in English, the question.
I clicked again on English.
Right, and can you hear the translation? Hello.
I can hear you.
Oh,
right
now you can. Oh, great.
Yeah.
Okay, so it's working. Great. Yeah, I was there all
Better
the
late
time, and
than
Magda
never.
was there all the time. But okay, now you can hear us. Perfect. Okay,
Sorry.
so let's take the questions.
Mhm.
Okay, so let's ask the questions. Just a minute. We have to find the questions first. There was a question about why you actually do not recommend that we use the word trauma.
Yeah, because, and again, this may be very culturally bound, but in the United States, people use trauma to mean anything that they didn't like that has happened to them. So and conversely, some people who, for example, have been abused by a parent don't see it as abuse. And so we just want to be very behavioral in asking questions. Then you make your own conclusions about whether it was a trauma or not.
I czy to też dotyczy słowa
And
zaniedbanie?
does this also concern the word neglect used with regard to children?
Yes. Well, most people who have been neglected are not able to say that, in my experience. They know it wasn't great, but when you use a word like neglect, you're assuming that they understand that they were neglected. I would use some of the words in the ACEs questionnaire, which is very, very good. It says stuff like, did you ever feel like nobody in your family cared about you? That's a good question. Better than were you neglected? I see a question in English. How many sessions do we need for that broad conceptualization? That's an excellent question. I think maybe one, and then you just dive in and you start, and that's when you get more and more information. My interest is more just that you're broad, not so much deep, and you'll get more deep as you go. But you could take forever, and I don't recommend that. It's much more useful just to do maybe one session and then start conceptualizing and start planning. I also see, how do we decide which symptom triggers which? That's another excellent question. I'm not pretending that at this level it's something that you could know, but you know some things just from your psychological knowledge. For example, you know that when people have insomnia, they're also more irritable. So we do know that that happens in that direction frequently. These are all hypotheses, and we don't actually know until we try. We're just hypothesizing what tends to go with what. Again, the most important thing is having a scientific mindset here. We don't know things a priori. We have to try and see if our hypothesis was correct. But those are good questions.
Czyli tak naprawdę okazuje się,
So
że
actually, it turns out that you're encouraging us to be investigators, explorers, right? People
Yes.
who really watch carefully, very carefully, these numerous aspects actually from the broader context of life of our clients, because these are various elements which can really have much importance in their lives.
Yes, exactly. I'm, a big proponent of evidence-based psychotherapies and protocols, but sometimes the downside is that we get too narrow and only focus on a narrow part of the person. And we have to be broader than that, in my opinion. So yes, exactly. You're being investigators, you're being very open to what you know from the broader literature, and being creative in your interventions also.
A jeszcze chciałam zapytać, jak...
I just wanted to ask another question. How do the clients react? How do they respond to if we are really going in depth into these many areas of morality, spirituality, all sorts of very intimate aspects already at the first session? So some really personal, tough topics. How do they respond to this?
I think that this may be very culturally bound also, but speaking from my perspective in the work that I've done in the US, people respond very well because you're just saying opening questions and see where they go. So for example, I might say, where are you with religion or spirituality? Or do you believe that life has meaning? What are your values? And you'll see what they give you. If they don't give you much, you don't need to pursue it. But yeah, it doesn't, I mean, we're doing an intimate business here. Doing psychotherapy is an intimate business. And so I've always had good reactions to that. But again, culturally, you guys might have different values around that. It might be different for you. And we never push anything. We never push anything. I'm not advising you to push something on somebody. But if you say, for example, you've been through so much and you've told me you're a very religious person, how do you see your religion helping you now? They'll either tell you or they won't, you know, and it's fine. I would never say, have you tried religion? I would only go with what the person had already used and encourage them to continue to use that.
No, ogromna porcja wiedzy, ogromne horyzonty,
There's a
szerokie.
huge portion of knowledge and a huge dose and broad horizons, as if we had had a meeting of NASA right here, you know. So we really managed to recognize this. We see that it's very complex what the client gives us. These are people who have been through so many different things, and there are so many matters which are, you know, they can actually make them even more depressed and things they are struggling with really strongly. Or sometimes these are aspects which may actually push them to search for new horizons in their lives. So that's a huge journey, really. And thank you for this. I think this has been really, yes. Professor Miller was right. You know, you are really, you inspire people. He was right about that. There's a lot of serious thought here, and this is food for thought for us to draw on what science gives us. Use this to support these people wherever they need it most.
Right. And wherever they will accept it, because I'm sure you'll have a number of people who are just not going to talk or whatever, but you could still perhaps help them be of service or help them be more active. So yeah, your patients are going to tell you what they will allow you to do. Well, thank you very much. I have such good feelings for you and know that we are very supportive here in the US, and I feel so strongly that you're doing wonderful work. Thank you.
Bardzo, bardzo dziękujemy za
Thank you very much for this support, for this really amazing, for these amazing things you have said. And yes, so our thoughts also go to you, and we're going to open, keep our eyes and ears open to everything that's going on with our clients. So thank you very much for these inspirations. Thank you. And let's thank all the attendees. This has been a truly amazing meeting, and this has really been of interest, and this has been so worth our while. So many things have given us so much to take away, so much food for thought, and we really feel encouraged to approach this boldly and take this boldly into consideration, to really meet with these people wherever they need it. So thank you for this inspiration once again. Thank you, and see you.
Thank you.
Soon we are having more
and
meetings.
contact
So
me
let's
contact me again if I can be of help. Thank you so much. Bye-bye.
I pozdrowienia dla całego Albuquerque.
And give our regards to Albuquerque and to New Mexico. So thank you very much.
Wspaniałym naszym tłumaczom. Ja ledwo mogę złapać.
Thanks. I would like to thank the interpreters. I find it hard to catch my breath, and well, not to mention the interpreters. So, okay. Thank you very much, and see you. Bye-bye.